All right, so in the area of psychological assessment in a biopsychosocial, this is probably one of the most critical ones when we're talking about diagnostic formulation is psychological history as well as current psychological assessment. So as you can see from this kind of little snippet here of a portion of a biopsychosocial form, you can see when we're talking about a biopsychosocial history, when we come to the psychological portion, that is where we are finding out symptoms. And so, what you're doing is you're kind of going through and ruling out and going through certain areas of diagnosis. So, in this case here, you're kind of looking and observing as well as asking the client, what brought you, what are some of your symptoms? What are you experiencing? What are some of the emotions you're going through? And as they say them, you can go in kind of a checkbox. Oh, they're experiencing depression, a depressed mood, they're crying, little energy. Okay, those three things right there are leading us down potentially the road of major depression or major depressive disorder. For example, MDD, major depressive disorder. Same thing with, no motivation, no interest in activities, changes in weight, feeling worthlessness, hopelessness, problems concentrating, irritable. Often that's kind of an interesting one. I'll kind of hold off on that one for now. But as you can see, these first questions right there are really focused on really kind of major depressive symptoms. However, there are some overlap. And so gathering just a bunch of symptoms that kind of cover broad categories really is the purpose of kind of this biopsychosocial, the psychological portion is really kind of broadly trying to understand what are some of the symptoms and areas that we can focus in on. Then there are finding out about sleep issues, which I mentioned in the previous section. Sleep can cause huge issues, both for depression, both for bipolar, for anxiety, for any number of disorders. Sleep problems are a big issue. Asking about any sort of manic episodes, and we'll get into this in later chapters, later discussion, but any sort of episodes that demonstrate manic type of behavior, grandiosity, impulsivity, high levels of energy or changes in energy. Then we talk about panic attacks, right? And that's also another chapter or we'll be getting into that here soon about panic attacks. And that's a very specific disorder or criteria for a potential disorder. Then we talk about constant worry and anxiety in general. And then we get over to these areas over here on the end that are a little bit more specific and hit on some diagnoses that can kind of quickly be ruled in or out potentially. So for example, if asking about hallucinations, paranoia, those things are, if a client is saying, yeah, no, I'm not experiencing any hallucinations or paranoia, perfect. Okay, we can kind of rule those out very quickly. Do they have any obsessions going on? No. Okay. So there you go. We can kind of rule things out very quickly as we take some symptomology or current symptoms. And you can do whatever you feel. You can do a check if they meet the, if those symptoms. I usually just kind of will quickly write down kind of, what are you experiencing? Tell me about your depression. Tell me about, do you get worried? Do you have anxiety? Essentially going through kind of a list of similar to this of just broad-based, broad categorical symptoms. That'll help kind of give you a picture of different areas that you may want to focus in on. These last couple, as you can see, thoughts of death here, that certainly can be tied to major depressive disorder, but there are other DSM criteria that have to do with threats of suicide or thoughts of suicide. So again, what we're doing is we're taking all this kind of smattering of symptoms and we're trying to now begin to somewhat lump them into categories or at least get an idea of what symptoms are there, and then we can work with our supervisors to sort those out. But a form such as, or a checklist such as this can be very helpful in the beginning as clinicians to kind of quickly narrow down what symptoms and signs are being displayed by patients, and that can quickly help you develop your diagnoses. Let's see. As you go through there, one other thing I wanted to bring up is, as I mentioned in class, even with all of these things, so let me just highlight it. Even with all this area of emotions here, one thing you'll definitely want to find out about, as I mentioned in class, is here we go, the frequency, duration, and well, that is super bad, and the severity and chronicity. Man, that is horrible, but you get the picture. So with all of these symptoms, whenever you're talking about symptoms or symptom gathering, find out about the frequency of, of these symptoms. How often do you feel depressed, right? That's frequency. Duration, for how long have you felt depressed? When you do have a depressive time period, is it for one day? Is it for a week? Has it been, how long does those symptoms last? Then severity, is it mild kind of depression? Is it moderate? Is it severe? We kind of spoke about in class about suicidal thoughts and severity, and so you can kind of go off of those indicators that I usually, if a person is kind of having somewhat mild to moderate depression, typically might involve some passive and kind of early active, somewhat active suicidal thoughts, but usually with no specific plan or intent. If a person is starting to develop or having much more active thoughts or has any sort of plan or intent going on, that's usually for me when it kicks it into severe depression. So that's what I've done for quite some time. In this psychological history, you'll notice it's important to find out, we spoke about this in class, you'll want to find out if they've had any previous suicide attempts. That'll give you some insight into their symptomology, into potential disorders that you may fit the criteria for the DSM. So finding out about previous suicide attempts. When did it happen? Where did they end up? Was it in the hospital? How long did they stay there? That also lets us know about risk factors. If you've had a person who's had multiple suicide attempts sitting in front of you, that's something you'll want to know because that puts them in a different category or a higher risk for future suicide attempts. Then we have homicidal thoughts. That's always something that we want to cover and just rule out, especially, ethically with the Tarasov case, duty to warn if we need to. The vast majority is sometimes never hear that, but there may be those times that somebody will surprise you and say, yeah, I've been thinking about hurting somebody. Then you'll want to move on and talk about any past or current mental health diagnoses. This really gives you some insight. Maybe they've been receiving mental health care for 15, 20 years. Find out what diagnoses they've been given before or what their counselors or psychiatrists have told them previously. That way you can kind of see, are you seeing the same thing currently? And also, there's no sense in bringing forward a diagnosis if they don't currently meet the criteria. That's what's so interesting is that sometimes some counselors will have a tendency to be like, oh, you were diagnosed by another counselor a few years back with panic attacks, let's say, for example. And so sometimes a counselor will just go ahead and diagnose them with panic attacks when in fact maybe it's been a year or so since they've had a panic attack. They're no longer meeting the criteria. They're no longer having those, and so it wouldn't be appropriate to treat them for panic attacks that they're no longer having, even though they previously had the diagnosis. I already mentioned about medications, but even in a psychological history, find out about specific psych meds that they're taking. Ask about who's prescribing those medications, and find out about any past medications that they've taken. That'll give you a really good picture as far as, are they kind of more of those what they call treatment resistant clients, which they've tried pretty much every medication under the sun. So finding out about previous medication history is really important. It can tell you a whole lot of how long they've been treated, what they've been treated for. Then going into family history, this area here can really peel back the layers of, let's say you have a dad who had bipolar, or a mom who had significant anxiety and depression, or a sibling who has schizophrenia. All of those things you'll want to know as part of a psychological assessment, because that'll help you with your own diagnosis of your patient, because it may point to, oh my gosh, like he said his dad had bipolar. We know there's some genetic inheritability factors there, and so you can begin to say, oh my gosh, yeah, I'm seeing that now. I can see kind of these different traits that maybe it wasn't on your radar before, but now you realize there's some maybe family link to that. You can then begin to explore that area as well, that maybe it wasn't on your radar, but now it is. So family history is critical because it can kind of open a window or give you insight into possible diagnoses that you didn't even consider. And then finally, last but not least in this section, is finding out about previous mental health treatment. Have they been to other counselors, other psychiatrists? Was it hospital? Was it day treatment? Was it outpatient? How long did they go there? All of those things are critical. You can even ask, did it benefit you? What did you find helpful? What didn't you find helpful? Those things will help you as a counselor know how to either do more of things that helped, or do less, or avoid kind of reinventing the wheel, or kind of going through some problematic times with that client, if we can avoid that by just asking them what was helpful and maybe what wasn't so helpful with the treatment that you received. And that again can give you a whole lot of insight. There you go. That's kind of the psychological portion of the biopsychosocial. Again, the main focus here is going to be symptomology, which you're going to want to focus on frequency, duration, severity, and chronicity. Chronicity, again, being when did this start and how long has it been going on? Is this from childhood, adolescence, early adulthood? Is it kind of onset, middle age onset? Those are questions that you're going to want to gather and be very specific, because you're going to need that criteria when we open up the DSM and you've got to start matching it up. This will help. That's why you need to do this in this section here. And that is the psychological.